So the fourth and the final talk of the session is by a person who is one of the highest cited authors and belongs to Pakistan. He's going to talk about long-term benefits of achieving SVR in HCV patients. I would like to invite Professor Adeel Ajwad Bhatt. He's Professor of Medicine, Population of Health Sciences at Will Cornell Medical College. He held the post of inaugural Chief Quality Officer at Hamad Medical Corporation. He was the first director of Hamad Healthcare Quality Institute, Vice Chair, Department of Medicine, and Director, Clinical Epidemiology Research. Dr. Bhatt completed his residency in internal medicine in New York, and his fellowship is in infectious diseases in New Orleans. He also holds a master's degree in clinical research from the University of Pittsburgh. His introduction is a bit long, but he is a name that I cannot do justice with. So I would like to ask him to take the mic. Thank you very much, sir.
Thank you. Assalamu alaikum. जुमा पढ़ने के लिए सब तैयार हैं? मैं ख्याल में वो भी शुरू करा देते हैं यहीं पे इसके बाद. First of all, I would like to thank the organizers and the scientific committee for inviting me. My association with PSH spans about 5 to 6 years now. So although I joined a little late, but I'm no less enthusiastic and no less a supporter of PSH and all the excellent work they do. And today they asked me to talk about the long-term benefits of achieving SVR in patients who are infected with Hep C. So these are my disclosures, but none of them are related to my current talk. So I'll talk about 5 things today. I will talk about treatment cascade, and I'll tell you why that is important. And then I'll talk about the importance or the association of Hep C and its treatment with survival, cardiometabolic outcomes, patient-reported outcomes, and certain cancers. And a lot of work that has been done in at least the first 2 questions has been done from our team from this study that we created a long time ago called Archives. And some of you have heard and seen the data from these electronically retrieved cohort of Hep C infected veterans. And this is how we created this database, which is one of the largest database of Hep C infected people in the world. And the beauty of this veterans database is that it is longitudinal and it is national. It transcends geography in the United States. And we update these data every year. And at the most recent iteration, we have more than 410,000 Hep C infected people and same number of controls with extensive demographic, clinical, laboratory, and other data. And we have answered a lot of questions related to Hep C epidemiology and natural history from these, and some of them are listed out here. But let me start by a few questions. When I started, when I got interested in Hep C about 22 years ago, some of the most simple questions were unanswered around a cascade of care for Hep C. For example, how many patients who have Hep C get started on treatment for Hep C? I mean, we didn't have the answer for that at that point in time. And through this database, we answered that question that in 2003, less than 12% of people with Hep C ever got initiated on treatment for Hep C. That's a staggeringly small number. Now, granted that those were the days of interferon and ribavirin, which were difficult to take, and Hep C was just one of the newer kids on the block, so to speak. We repeated that study a few years ago in 2017 or so with twice the number of people, and this is the era of directory-acting antiviral agents, and the number has indeed jumped up to more than 50 to 60%, and now the number is even higher. So a vast majority of people now do start on treatment. And the reason I'm sharing this data is because we all know that the medicines that we have for Hep C do work. There is no question, there's no doubt in our mind about their efficacy and their real world effectiveness. The question now is, can we get those people into treatment? And once we get them into treatment, can they finish treatment and get the benefit of achieving cure, virologic cure? So we also answered the question about how many people completed treatment. And in those days, only about 1 in 5 people were able to complete a full course of treatment. In the days of DAAs, this number is over 90% or so if they get into care. Now, we were also very lucky to create what we call a seroconversion cohort. So as you would know, that one of the most difficult aspects of studying natural history of Hep C is determining when did the person actually get Hep C. Since we have such a large number of people in the database and we have longitudinal data, we had several thousand people who had a negative antibody test and a subsequent positive antibody test. So we were able to pinpoint the time of infection with reasonable accuracy. And what we've shown here is that people who have Hep C clearly have a higher risk of cirrhosis and hepatic decompensation. And this risk starts relatively early, more earlier than what we used to think a few years ago. Adherence is another important issue, and we showed in these elegant studies that in the interferon era, remember the 80-80-80 rule, that 80% of the drug had to be taken for 80% of the time, or 80% of the dose, and so on and so forth. In our studies for the DAAs, actually that does not hold true. And that is fortunate to some degree, because even if their adherence is down to about 60% or so, they still achieve SVR at the same rates as if their adherence was 100%. Now, that is, of course, not a license to allow them to miss doses or not be adherent to treatment that we prescribe, but there is a buffer that we have in the days of, in the era of DAAs. Another very important factor, which will become very important in realizing the benefits of SVR, are getting them on treatment. And the burden of Hep C in Pakistan, in the US, and globally is so high that hepatologists, gastroenterologists alone will never be able to take care of all those patients. So what we showed that over a period of 10 to 15 years or so, the treatment paradigm has shifted quite significantly from GI hepatologists and specialists treating them to other specialties treating people with Hep C. So about a quarter or more of the people who are Hep C positive are now treated by internists. Another quarter by non-MD physicians, meaning physician extenders like nurse practitioners and other advanced care practitioners. And even acute care physicians and family practitioners are now treating Hep C. And this is a very welcome thing, because now we can get more people into care. And of course, we and others have shown through a series of studies that these drugs work even in the real life and so. So moving on to the benefit of treatment and its impact on survival. Let's start with survival first. So even in the interferon era, we were able to show in this key landmark publication towards your left that people who get started on treatment have a very clear survival advantage compared to those who do not get started on treatment. And if you remember, PEG interferon ribavirin used to be given for 48 weeks. But we showed that even if they do not complete a full course of treatment, even if they got about 24 weeks of treatment, they had a survival advantage that was much better than those who were untreated. It wasn't as good as who completed a full course of treatment, but they still had survival advantage. And we've repeated these studies over a period of years using different cohorts and different drug regimens. And in all cohorts that we study, people who get treated have a very, very clear survival advantage. If they have SVR, if they achieve SVR, their advantage is much more marked. If they're non-cirrhotics, their advantage is much higher. But even in difficult to treat people like cirrhotics, advanced liver disease, who do get treated for Hep C, this advantage is very clear. So in short, Hep C saves lives, it improves survival, and that is very clear. Now, most of the Hep C survival studies have been done looking at overall survival. Does it matter about liver-related mortality? Because ultimately Hep C affects the liver as a primary organ. And again, we showed very clearly that liver-related mortality is significantly reduced in people who get treated, and attainment of SVR is associated with several-fold improvement in survival benefit in those people. And no matter which drug regimen you use, if you attain SVR, there is a very clear advantage in reduction of liver-related mortality. So moving on to some of the other organ systems that talked about, again, about 10 or 12 years or so ago, we showed a clear link between Hep C and coronary artery disease. And in this study, we studied close to 82,000 Hep C infected people and even larger number of matched controls. And Hep C was associated with about a 27 to 30% increase in risk of CAD events, independent of all other risk factors. A couple of years ago, we did another study to look whether treatment actually makes any difference in this association. And we were able to show that people who get Hep C treatment have a reduction in the incidence of coronary artery disease and cardiovascular disease events after treatment. Now, this is seen both in people who get treated with older regimens with PEG-RIBA as well as the DAA regimens, but the relative decline is much more for those who get treated with the DAA regimens. And this is independent of SVR. So there's something in the regimens, which we don't know what, that is associated with a sharper decline in incidence of cardiovascular disease events. On your right, you can also see that those who have SVR also get significant benefit compared with those who get treated but do not attain SVR. But that decline is, that slope is a little less than what we see in between in PEG-RIBA versus DA. So that leads us to conclude that regimens are at least as important, if not more important, in reducing this incidence. Several people have shown an association between Hep C and diabetes. We showed a couple of years ago that if you treat Hep C with any regimen, you reduce the incidence of subsequent diabetes mellitus, type 2 diabetes. Here, attainment of SVR seems to be more important than the regimen, because in people treated with the PEG-RIBA regimens, you did not see such a dramatic benefit, but those who were treated with the DAA regimen and attained SVR, they had a sharper decline, which was statistically significant and I think clinically relevant as well. So treating Hep C, attainment of SVR is also associated with a reduction in subsequent diabetes in these people. In more recent years, a lot of emphasis is being put on how the patients feel after any disease diagnosis or after the treatment has been given. And actually, these outcomes are now mandated in several registration trials as well. A patient with Hep C will not know if he or she has achieved virological cure, because that is a blood test that you do to find out if the virus has gone away or not. What the patient will know is whether the symptoms have gone away, whether the quality of life is better, whether they're able to get back to work or not. And these are all patient-related outcomes which have now been studied well by several groups. And we wrote a review on this a couple of years ago as well, looking at several of these outcomes, including physical functioning, your mental status, your functional assessment, your ability to get back to work, and so on and so forth. So work-related impairment and getting back to work. All those things are improved in people who are treated, particularly if they have a virologic cure. So in other words, not only do you cure their blood, meaning you remove the virus from their blood, you improve their biochemical markers, but you also improve patient-related outcomes and make them more functional and happier. Of course, the archetypical malignancy associated with Hep C is hepatocellular carcinoma. But there are several other malignancies that have also been associated with Hep C. These include non-Hodgkin's lymphoma, Waldenstrom's macroglobulinemia, more recently intrahepatic and extrahepatic cholangiocarcinoma, gastric cancer, pancreatic cancer, even colorectal cancer have been associated with Hep C in some studies. Now, this is a study that looked at the association of 2 or 3 of these cancers and cryoglobulinemia. Of course, with the hepatocellular carcinoma, I'll show you some data. That is the strongest association with viral hepatitis. But even in people with non-Hodgkin's lymphoma and other cancers, there is a benefit of treating these people and attaining virologic cure. This is one of the study done by one of our fellows at MGH who worked with me for a season, looking at hepatocellular carcinoma's free survival in cirrhotics versus non-cirrhotics as well. And again, there is very clear demonstration that if you achieve a virologic cure or attain SVR, even in people with cirrhosis, the incidence of or the risk of hepatocellular carcinoma is significantly decreased. Same is the case with lymphoma, that in fact with non-Hodgkin's lymphoma, one of the primary treatments for early lymphoma is actually giving Hep C treatment. And they've shown that if you do that, the burden of lymphoma is quite significantly reduced by that treatment alone before you need to go on to chemotherapy and other modalities. And that risk reduction can be in the order of magnitude about 70% or so. Now, cryoglobulinemia, you may remember, is one of the earliest manifestations that we recognized associated with Hep C. This recognition goes back 20, 30 years or so. And the manifestations of cryoglobulinemia and cryoglobulinemic vasculitis, which are seen in about 10% of the patients. These include purpura, weakness, joint pains, general weakness, myalgias, peripheral neuropathy, and even kidney involvement and so. Now, you can see that with treatment, there is a significant clinical response or complete clinical response in up to 70% of the people who got treated for Hep C. So a lot of these manifestations that I mentioned, purpura, arthralgias, general weakness, polyneuropathy, all of these get better. And I remember one of the first patients I treated for Hep C in my practice, that was I think in the late 1990s, and I had given her interferon and ribavirin. And she was debilitated, could not even walk. She had lost her job and could not get out of bed. And when I treated, within 24 weeks, she was up and about, and by the end of treatment, she was back to work. At that time, I could not associate that very well, but subsequently, we figured out that how important this Hep C treatment is for their functional assessment and joint pains, which is and weakness which this patient had. So in conclusion, Hep C can now easily be treated with cure rates routinely above 90% even in the real world or so. The challenge now is getting people into treatment and getting them to complete a course of treatment. And I showed you data that this can be done. We're already on that path. The more people we get into treatment, the more people will get virologic cures, and more people will get better patient-related outcomes and all the other benefits associated with it that I just showed you. Effects of Hep C go far beyond the liver. In fact, most organ systems may be affected, and all those extrahepatic manifestations and associations that we talked about need to be identified and addressed. For many extrahepatic manifestations, the actual treatment, the first-line treatment, may actually be giving Hep C treatment, and some of those things may either get better or may get resolved. And finally, overall mortality and liver-related mortality, which is increased in Hep C, can be dramatically reduced by treatment and attainment of SVR. I'll stop here and happy to answer any questions if there is any time.
Thank you very much, sir. Because of we just run out of time and we are getting ready for Jummah prayers, I would request the chairs to please wrap up the session. And please, Professor Nasser, if we can say a few words.
I thank all the speakers, especially this fabulous session was started by the Professor Arshad Kamal Bhatt, and he, as always, was spot on and did justice to this topic in a very comprehensive manner. And Dr. Farooq has really stimulated us towards the multidisciplinary approach in a comprehensive and a most enthusiastic manner to really make these patients' life easier when the transplant is not on. And Professor Rafael has given us the most important message: C, B, think of D. I think this is a very important message. And last but not the least, what we've seen that Professor Adeel rightly said, the challenge still remains with us in regard of Hep C treatment is equitable manner of treatment is still far away, especially with the resource deficient people like us. And overall well-being of these patients, we do see this pattern. And I think so the liver-related mortality surely decreases with time. Thank you.
Thank you very much, sir. With this, I announce the end of the Potpourri session. Our next session is going to be a case-based review on the essentials of hepatology from guidelines to practice. With this, I would like to ask Professor Arif to please come on the stage. He has an announcement to make.
We have such good moderators that I have been sort of reassigned this job of only announcing dinner and lunches and all that. So and I'm very proud of it. Thank you very much. We will be serving lunch boxes next door. Some people have meal tickets, so they can pursue that. Lunch boxes, the process will be, please, they are being served there between now and 1:45 p.m. You can go there, they will punch a hole into your ID to make sure that the lunch box has been delivered to you, and you can have lunch box at your convenience. I would request ladies can go there now first, or even some gentlemen if they want to join us, but the lunch boxes will be there. The Jummah is at 1:30, and inshallah we will start sharp on time according to this schedule the moment we get back at 14:15. So we'll see you then. Some very exciting talks in the afternoon. Please send your colleagues that this is being telecast on Zoom also, so they can join us there also. Thank you.